గుడ్ మార్నింగ్ ఫ్రెండ్స్. ఇండియన్ మెడికల్ అసోసియేషన్ సంబంధించి రెండవ రోజు రాష్ట్ర స్థాయి 66వ కాన్ఫరెన్స్ జరుగుతుంది గుంటూరు మెడికల్ కాలేజీ జింకానా స్టేడియంలో. ఫస్ట్ డే సదస్సులో చాలా కీలకమైన అంశాల మీద చర్చ జరిగింది. ప్రధానంగా అయితే ఏ అయితే కీలకమైన డిసీజెస్ ఉన్నాయో, అంటే ప్రపంచాన్ని శాసించిన డిసీజెస్, దీర్ఘకాలిక వ్యాధులు, ప్రధానమైన రోగాలు ఏవైతున్నాయో ఆ రోగాల విస్తరణ, వాటి అధ్యయనం, తర్వాత వాటి నియంత్రణ, ఈ అంశాల మీద కూలంకషంగా టైం షెడ్యూల్ ఇచ్చి టాప్ మోస్ట్ డాక్టర్స్ ఎవరైతే ఉన్నారో ఆ డాక్టర్స్ తోటి సంబంధిత సబ్జెక్టుల మీద విపులంగా డిస్కషన్ చేశారు. నిజంగా ఇలాంటి సదస్సులు చాలా కొత్త అధ్యయనాలకి బీజం వేసాయని చెప్పొచ్చు. ఎందుకంటే ఏదైనా రోగంతో హాస్పిటల్కి వెళ్తే వాళ్ళు విశ్లేషించి రోగికి నయం చేయడం మాత్రమే చూసాం, కానీ దాని మీద విపులంగా చర్చించిన సందర్భాలు చాలా తక్కువ ఉంటాయి. అసలు ఆ డిసీజ్ ఎలా వస్తుంది, వచ్చిన డిసీజ్ ఏ స్థాయిలో ఉంది, దాన్ని ఆ ఉధృతిని తగ్గించేది ఎట్లా, తర్వాత ఉధృతి తగ్గడంతో పాటు సమూలంగా నిర్మూలించేది ఎట్లా, రావడానికి గల కారణాలు, వచ్చిన తర్వాత నిర్మూలించడానికి తీసుకోవాల్సిన చర్యలు చాలా అద్భుతంగా చాలా బాగా విశ్లేషిస్తున్నారు. ఫేమస్ ప్రముఖంగా ఉన్న డాక్టర్స్ ఎవరైతే ఉన్నారో అందరూ కూడా టాప్ మోస్ట్ డాక్టర్స్ అన్నమాట. అలాంటి అమూల్యమైన సందేశాలను వినడానికి ఏమాత్రం మిస్ చేసుకోకూడదు. ఎందుకంటే 16 సంవత్సరాల తర్వాత మన గుంటూరులో ఈ IMA సదస్సు జరుగుతూ ఉంది. 66వ సదస్సు అనమాట. 66 సార్లు, ఇప్పటికి 65 సార్లు జరిగింది. ఇది 66వ సదస్సు. 16 సంవత్సరాల తర్వాత మన గుంటూరులో జరుగుతూ ఉంది. అలాంటి సదస్సుని నిపుణులు ఎవరైతే రోగాల పట్ల అవగాహన పెంచుకోవాలనుకుంటారో, ఎవరైతే అధ్యయనం చేయాలనుకుంటారో, పూర్తి స్థాయిలో అవగాహన పెంచుకొని సమాజానికి మేలు చేయాలనుకుంటారో వారందరూ కూడా మస్ట్ అండ్ షుడ్గా ఈ సదస్సులకు ఎంతగానో ఉపయోగపడతాయి. సో ఆ విలువైన సమయాన్ని ఇలాంటి సదస్సులకు వినియోగించుకోండి. ఎందుకంటే ఇలాంటి సదస్సులు అరుదుగా జరుగుతాయి. ఇప్పుడు మనం చూస్తా ఉన్నాం, హాస్పిటల్ అంటే ఒక బిజినెస్ లాగా మారింది. వ్యాపారం తప్ప వేరే కోణంలో చూడలేకపోతున్నారు అనమాట. అలాంటి వైద్యాన్ని వ్యాపారంగా కాకుండా సేవగా భావించడానికి చేపట్టే కార్యక్రమాలను కరెక్ట్గా అర్థం చేసుకొని అవగాహన చేసుకుంటే మాత్రం ఎంతగానో ఉపయోగపడతాయి. అట్లా ప్రజెంట్ రోగాలు బారిన పడి ఇబ్బంది పడుతున్న వాళ్ళకి అవగాహన వస్తుంది. తర్వాత అలాంటి రోగాలు దరిచేరకుండా ఉండాలంటే ప్రిస్క్రిప్షన్ ఏవైతే ముందుగా మనం తీసుకోవాల్సిన జాగ్రత్తలు ఎలా ఉంటాయో ఆ జాగ్రత్తలు మనం తెలుసుకోగలుగుతాం. 10 మందికి సమాచారాన్ని షేర్ చేస్తూ, వాటిని విశ్లేషిస్తూ, వాటి మీద అవగాహన పెంచే ప్రయత్నాలు చేస్తుంటే చాలా వరకు మనం ఆదిలోనే అలాంటి వాటిని మనం నివారించవచ్చు. అలాంటి అద్భుతమైన కార్యక్రమం ఈ MIA రెండవ రోజు సదస్సు. ఈరోజు కూడా విస్తృతంగా డాక్టర్స్ మొత్తం నిన్నటి వరకు అయితే 2500 మంది డాక్టర్లు ఈ సదస్సుకు రిజిస్ట్రేషన్ చేసుకున్నారట. 2500 మంది డాక్టర్లు చూడండి. ఫేమస్ టాప్ మోస్ట్ డాక్టర్స్ ఎవరైతే ఉన్నారో ఆ టాప్ మోస్ట్ డాక్టర్స్ 2500 మంది డాక్టర్లు ఒకే వేదిక మీదకి వస్తున్నారు. వారి అభిప్రాయాలు, వారి సలహాలు, సూచనలు మనకు ఎంతగా ఉపయోగపడతాయో చెప్పండి. నిజంగా పాజిటివ్గా ఆలోచించి విలువైన సమాచారాన్ని మనం సేకరిస్తే ఇలాంటి ఏదైనా ఒక విపత్తు అంటే ఈ ఆరోగ్యకరమైన విపత్తులు ఎదురైనప్పుడు ఈ సదస్సులో వాళ్ళు ఇచ్చిన సలహాలు, సూచనలు డెఫినెట్గా ఉపయోగపడతాయి. కోవిడ్ సమయంలో ఎదుర్కొన్న సమస్యల మీద కూడా విశ్లేషణగా బ్రహ్మాండంగా నిన్న అధ్యయనాలతో కూడిన విశ్లేషణ నిన్న చూసాం. కానీ చాలామంది ఇలాంటి అంటే అంత ఆసక్తి చూపరు, ఓపిక ఉండదు. కానీ తప్పకుండా ఇలాంటి సదస్సులని మనం ఉపయోగించుకోవాలి. 16 సంవత్సరాల తర్వాత మన గుంటూరులో ఈ IMA సదస్సు జరుగుతూ ఉంది. ఇండియన్ మెడికల్ అసోసియేషన్. డెఫినెట్గా సదస్సును వీక్షించండి. అందరూ ఇక్కడ వచ్చేదంతా డాక్టర్స్ కాబట్టి, పబ్లిక్ రారు కాబట్టి మీకున్న ఏకైక సాధనం లైవ్లో మీరు వీడియోలు చూడటమే. లైవ్లో కూడా అలా ఆంధ్రప్రదేశ్ యూట్యూబ్ ఛానల్ మాత్రమే మొన్న లైవ్ చేసిన నిన్న కార్యక్రమం మొత్తాన్ని. ఈరోజు కూడా లైవ్ కార్యక్రమం ఉంటుంది. సదస్సు ఆ ఉద్దేశాన్ని మాత్రం డెఫినెట్గా అర్థం చేసుకోగలగాలి. మంచి మంచి కార్యక్రమాలు పెట్టినప్పుడు మనం వాటిని సద్వినియోగం చేసుకోలేకపోతే వేస్ట్ కదా. అంత భారీ స్థాయిలో ఖర్చు పెట్టి అంతమంది డాక్టర్లు వారి విలువైన సమయానికి హెచ్చించి 2500 మంది డాక్టర్లు ఒకే వేదిక మీదకి వచ్చి వారి సలహాలు, సూచనలు ఇస్తూ ఉంటే అలాంటి కార్యక్రమాన్ని మనం వీక్షించకపోతే, అలాంటి కార్యక్రమాన్ని మనం అర్థం చేసుకోలేకపోతే వాళ్ళు పెట్టిన సదస్సుకు పరిపూర్ణత లేనట్టేగా. అలాంటి కార్యక్రమాలను తప్పకుండా వీక్షించండి. కొంచెం ఓపిక చేసుకోండి. మీ సమయాన్ని, విలువైన సమయాన్ని కూడా కేటాయించి డెఫినెట్గా చూడండి. నిన్న మన ఛానల్లో లైవ్ చేసిన వీడియోస్ ఉన్నాయి, అలాగే అప్లోడ్ చేసిన వీడియోస్ కూడా ఉన్నాయి. 3-4 వీడియోస్ ఉన్నాయి, ఒకసారి చూడండి. మంచి సమాచారం తప్పకుండా 10 మందికి ఉపయోగపడుతుంది. 10 మందికి చూసిన ప్రతి ఒక్కరికి ఉపయోగపడుతుంది. సో అలాంటి విలువైన సమాచారాన్ని మిస్ చేసుకోవడం ఈరోజు రేపు 2 రోజుల పాటు, అంటే 3 రోజులు, నిన్న ఈరోజు రేపు 3 రోజుల పాటు ఈ విస్తృత స్థాయి సమావేశం, నేషనల్ కాన్ఫరెన్స్ చాలా బాగా చేస్తూ ఉన్నారు. అలాంటి అద్భుతమైన కార్యక్రమాలని మిస్ చేసుకోకుండా వచ్చిన అవకాశాన్ని ఇట్లా చేసుకోవడానికి మంచి కార్యక్రమాలు కదా. ఒక వేదిక మీదకి అంతమంది డాక్టర్లు వచ్చి వారి సలహాలు, సూచనలు, కొత్త వేరియంట్స్ వచ్చిన రకరకాల, ఇప్పుడు మనం చూస్తూ ఉన్నాం, అనేక రకాల జబ్బులతోటి బాధపడుతూ ఉంటాం. ఎప్పుడు ఎలాంటి వేరియంట్ మన మీద దాడి చేస్తుందో తెలియదు. ఇలాంటి వాటిని విశ్లేషిస్తూ ముందస్తు అలర్ట్ చేయడం అంటే ఒక అద్భుతమైన కార్యక్రమం కదా. సో డెఫినెట్గా వీక్షించండి. మన అలా ఆంధ్రప్రదేశ్ యూట్యూబ్ ఛానల్ ద్వారా లైవ్ కార్యక్రమం మీకు లైవ్ ఉంటుంది. డెఫినెట్గా మీకు ఆ లైవ్లో డాక్టర్ వాళ్ళు మాట్లాడేది, వాళ్ళ సలహాలు, సూచనలు, వాళ్ళ ప్రజెంటేషన్ చక్కగా వాళ్ళు ప్రజెంటేషన్ చేస్తూ చర్చిస్తున్నారు కాబట్టి అందరికీ అర్థమయ్యే రీతిలో చాలా ఈజీగా ఉంటుంది. డెఫినెట్గా మిస్ కాకండి. ఇంకొక 2 minutesలో మనం అక్కడికి వెళ్ళిపోతున్నాం. చాలా చాలా పెద్ద విషయాలు మాట్లాడారు నిన్న ఫేమస్ డాక్టర్లు అందరూ కూడా. మనం ఆ డాక్టర్ని మామూలుగా కలవాలి అంటే అపాయింట్మెంట్ తీసుకొని రోజుల తరబడి వెయిట్ చేయాలి. అలాంటిది మనకి వారందరూ కూడా స్వయంగా డైరెక్ట్గా మనకి ఒకే వేదిక మీద వచ్చి వారి సలహాలు, సూచనలు ఇస్తున్నప్పుడు అలాంటి సదస్సుల్ని మనం మస్ట్ అండ్ షుడ్గా వినియోగించుకోవాలి కదా. ఈరోజు అంతర్జాతీయ ఆత్మహత్య బాధితుల దినోత్సవం ఉంటుంది. అంతర్జాతీయ ఆత్మహత్యల బాధితుల దినోత్సవం అంటే తాత్కాలికమైన సమస్యలకు శాశ్వత పరిష్కారాలు ఆత్మహత్యలు అనుకుని ఆత్మహత్యలు చేసుకునే వారు ఆ క్రమంలో ప్రాణాలు కోల్పోతున్న వారిని కాపాడదాం. ఇది దానికి కూడా ఒక దినోత్సవం అన్నమాట. వచ్చేసాం మనం వేదికకి. చాలా మంచి కార్యక్రమం, తప్పకుండా ప్రతి ఒక్కరూ వీక్షించండి మా లైవ్ కార్యక్రమాన్ని. చాలా భారీ ఎత్తున ఏర్పాటు చేశారు సదస్సు అయితే. జర్నలిస్ట్ అండి,
ఇక్కడ పెట్టకూడదు సార్,
అటే వెళ్తున్నామండి. మన మీడియా అండి మా దగ్గర ఉండాలి, మళ్ళీ వెళ్ళిపోతే మనకి తీసుకోవడం
అక్కడ కూడా దగ్గర ఇక్కడే
వెహికల్ తీసుకోవడం మళ్ళీ కష్టం కదా. మాకు
కష్టమే ఉండదు సార్, తిప్పుకోవడం టర్నింగ్ తిప్పుకోవడానికి ఉంది ప్లేస్.
గిరిజ గారు హాయ్ అండి. అవునండి, ఇక్కడే సదస్సు జరుగుతుంది. ఈ సదస్సు సంబంధించి నిన్న మనం మాత్రమే లైవ్ ఇచ్చాం. అందరూ సదస్సుకి రాలేరు కదా, ఓన్లీ విజిటర్స్ అంటే 2500 మంది డాక్టర్స్ మాత్రమే ఇక్కడికి వస్తున్నారు. ఇది మెడికల్ కాలేజీకి సంబంధించిన జింకానా ఆడిటోరియం అనమాట. జింకానా ఆడిటోరియంలో జరుగుతుంది ఈ కార్యక్రమం. అత్యంత పురాతనమైన కట్టడాలు అన్నమాట ఇవన్నీ కూడా. చూడండి ఎంత అద్భుతంగా ఉన్నాయి పరిసరాలు. ఇది దాదాపు 16 సంవత్సరాల తర్వాత గుంటూరులో జరుగుతున్న సదస్సు అన్నమాట. ఇది అంటే 66వ సదస్సు, ఇది నేషనల్ కాన్ఫరెన్స్. 2500 మంది డాక్టర్లు రిజిస్టర్ చేసుకున్నారు ఇక్కడ. దాదాపు నిన్న ఒక్కరోజే 2500 మంది డాక్టర్లు రిజిస్టర్ చేసుకున్నారట. దానికి సంబంధించిన ఎక్విప్మెంట్స్ అన్నమాట వీళ్ళందరూ కూడా. సెకండ్ డే షెడ్యూల్ ఇది. రేపటి షెడ్యూల్ అది. ఆర్గనైజర్ డాక్టర్ సేవకుమార్ అండి. ఈ కాన్ఫరెన్స్కి ఆర్గనైజర్ అనమాట ఆయన. సెకండ్ డే షెడ్యూల్, తర్వాత థర్డ్ డే లాస్ట్ స్పెసిఫిక్ ప్రోగ్రామ్స్ ప్రోగ్రామ్స్ దానికి సంబంధించిన మానిటరింగ్ వ్యవస్థ అంటే పాస్ ఇష్యూ చేయడం వాళ్ళకి సంబంధించి మధ్యలో క్విజులు ఉంటాయి. ఆ క్విజులకు సంబంధించి ఆల్టర్నేటివ్గా వాళ్ళు పెట్టుకున్నారు. రిజిస్ట్రేషన్ ప్రాసెస్ కాన్ఫరెన్స్ హాల్లోకి వెళ్దాం.
So all this, many types of missed opportunities to vaccinate them and prevent these infections from occurring. And also travelers. So just to see, this is the latest guideline given by the CDC and ACIP. So this shows the list according to the age, the different vaccines that are recommended. But you can see this actually with a simple app that is very much usable. I still follow this whenever I have a doubt. And also, we also have the Indian guidelines that were recently released last year by API mainly in collaboration with almost 14 other national societies. So they also released the guidelines which is almost similar to this. So, and this, but there are different situations, different conditions available. There are still many more vaccines that are required. So today I'll just be roughly going about some of the vaccines and some of the recent vaccines and how to improve ourselves with vaccination practices. So the first and most important in the current situation, where we are talking of more respiratory illness and its prevention, is influenza vaccine. In the current situation, what I tell my patients if someone asks, are the vaccines safe and all? Many have taken COVID vaccine. COVID vaccine was prepared in 1 year. Influenza vaccine has been there since 50 to 60 years, gone through rigorous testing. It was given to more patients than what COVID patients received. So definitely it is a good, safe vaccine that can be given in the current times to prevent pneumonias, especially viral pneumonias, and the timing is same. So that is to be given ideally before the monsoon months or before the winter months to have the maximum effect. And most of the patients it is indicated influenza vaccine. Most important precaution while giving this is to take the updated vaccine, because this vaccine is updated every 6 months. But at least 1 year you have to take, every year you have to take the vaccine. So you have to take the updated vaccine to get the maximum benefit. And next important is the pneumococcal vaccine. So here you mainly have two types, pneumococcal conjugate vaccine PCV13 or pneumococcal polysaccharide vaccine or PPSV23. So these are the 23 and 13 out of serotypes that they cover. So if PPSV23 is covering more, why is there still PCV? And why is it more important? Because that induces long-term benefit and more immunogenicity compared to PPSV. So still PCV is the first to be given and it induces long-term benefits. So again for pneumococcal also you have wide range, especially important when it comes to asthma patients, CSF leaks and diabetes. So if you ask me what to be given, PCV or PPSV? First PCV, then PPSV at least weeks later or 2 months later. So that should be the best to be given. So recently, I think Amitabh Bachchan has also been in the promoting some of the vaccines. So this was the new vaccine that has come up from GSK regarding herpes zoster. So we'll first look into briefly about it and then come. So it is the chickenpox virus or the varicella that causes the primary infection, and by age 50, 99% of people would have already contracted the varicella virus. But as the age progresses, that is when the shrinkage.
సార్ గుడ్ మార్నింగ్ సార్. లైవ్లో ఉన్నాం సార్. ఇప్పుడు ఈ సదస్సు ముఖ్య ఉద్దేశం చెప్పండి సార్, బ్రీఫ్గా 2 మాటల్లో.
ఈ సదస్సులో రాష్ట్ర స్థాయి సైంటిఫిక్ సదస్సు మరియు IMA స్టేట్ సదస్సు. దీనిలో కౌన్సిల్ సమావేశంలో అందరూ ఎదుర్కొంటున్న సమస్యలు అవన్నీ చర్చించడం జరుగుతుంది. అట్లానే పబ్లిక్ హెల్త్ గురించి డిస్కషన్ జరుగుతుంది. సైంటిఫిక్ సదస్సులో 40 పైగా స్పీకర్స్ పాల్గొంటున్నారు. రాష్ట్ర స్థాయిలో జరుగుతున్న సదస్సుకి 1500 పైన రాష్ట్ర స్థాయి, అట్లానే పక్కన తెలంగాణ నుంచి కూడా వైద్యులు హాజరయ్యారు.
మొత్తం ఇప్పటివరకు మనం ఎంతమంది రిజిస్టర్ చేస్తున్నాం సార్?
వస్తా తనం
జర్నలిస్ట్ అండి, నా పేరు దశరథ రామరెడ్డి. అలా ఆంధ్రప్రదేశ్ అండి. అలా ఆంధ్రప్రదేశ్. ఎంతమంది రిజిస్ట్రేషన్ చేసుకుంటారంటే అది చెప్పలేకపోతే ఎట్లా, దానికి భయపడితే.
So we have two again, we need two for two serotypes, men ACWY and men B. This is especially important for our Muslim friends who go to Hajj for traveling. So that is the meningococcal blend. So whoever are traveling has to do that. In other patients, especially dyspnea and complex deficiency patients also, meningococcal vaccine is important. Most important thing, especially dyspnea patients or post-splenectomy patients, is when you combine meningococcal vaccine with pneumococcal vaccine, the effect of pneumococcal vaccine goes down. So you have to maintain a gap of 2 months again for pneumococcal conjugate vaccine and men ACWY actually. So next, Haemophilus influenza. This has lost its importance In adults, mainly it is only used in case of dyspnea patients, capsulated organism, and post bone marrow transplant patients. Tdap, this is gaining importance nowadays, especially so first DTP and Tdap are different. We have different dosages for the pediatric group and the adult group. And for the adult Tdap, it is mainly now gaining importance among pregnant females, where they take the second dose, first TT and the second dose as a Tdap, that is seen to prevent even pertussis in younger infants before they take the DTP vaccine. And next is the hepatitis B vaccine. I'm sure at least this is one important one for the healthcare workers and everyone are updated. See, most important thing is knowing your titers, because when you have an accidental prick, then you will be considered, I don't know whether I am immune or not, I have taken the vaccine. If you have taken the vaccine, just get your titers and know that, okay, I am safe. Then you will be more happy and confident to do your procedures. And also we have newer vaccines like Epsilon B and other rejuvenated vaccines to improve the immunogenicity. And this again has become popular with some of the social media marketing for HPV. So both males and females actually can take the vaccine. Ideally to be taken before the initial sexual contact at 9 to 14 years, but can be taken up to 26 definitely, even up to 45 with a mild decrease in efficacy. So, but the main problem is you need 3 doses actually to have the complete efficacy. It was seen that many of the people are not completing those 3 doses in their later having a problem. So other than this, these are introduced 2 which are important in our scenarios. So of which I have come here for 1.5 to 2 years now, approximately. I have seen ton of hepatitis A cases. And these are mainly young females who have recently joined the colleges, go about eating outside food, especially pani puri, and they come back with hepatitis A. And it can be dangerous some of the times, and it will be disturbing them for almost 1 month. So we have, it is a simple vaccine preventable disease, 2 doses that can be given, it will be very useful for those patients. And India is the epicenter for typhoid when it comes to. We actually have a vaccine that is efficacious against enteric fever, that will definitely decrease your rates of enteric fever, and it is recommended in endemic area, but no one wants to promote it. That is why I say it is quite negative. It is developed by India, sold outside, but less used in India. So that is the situation that we are in when it comes to adult vaccination. And what the most important people, what they found in outside states is food handlers. So for them, for food handlers, typhoid vaccine is important. For us, there are many other sources where we can get some typhoid from. And there are very less, it is a very safe vaccine and is very less. Other than this, there are also other new vaccines coming up. So when you are done with influenza, the next important viral illness will be RSV. So we have the RSV vaccines that are coming up, already approved. But other than that, I am most interested because still we see a lot of dengue patients. Dengue is also going to be a vaccine preventable disease. We have WHO approved vaccines that are being given for dengue in other states, yet to come into India. But there are promising studies. In the coming few years, dengue is going to be a vaccine preventable disease. That is all I can say. So just to inculcate more. So we had a successful story of preventing one of the big pandemic like COVID. So why did we stop that? So just to give a thought, what was the most important reason that COVID-19 was successful? So was it giving free of cost? Was it making it mandatory for even day-to-day tasks, going to a theater, going to a mall, you need a vaccination certificate, going out of state, you need a vaccination certificate. So was that important? Or the campaigning, door-to-door campaigning, was that important? And the supply chain. So when all these people have come, the supply chain, to maintain the supply chain, that is also important. And also the safety of vaccines. So all this came together. So we need to implement this when it comes to other diseases as well and improve the vaccination rates among adults. So my final take point is try to place the immunization schedules in your offices so that patients who come at least see that they can take a vaccine, that there is vaccine preventable diseases, and if they want to take, definitely we should try to improve our patients' health and prevent them from getting these diseases. So, and also this is antibiotic awareness, AMR awareness week that we are having. So vaccines also will help in decreasing your AMR. It will decrease your infections, it will decrease your use of antibiotics, and will also help in your AMR. So thank you for this opportunity.
Thank you, sir. Thank you, sir. I'm completing before time. One or two, please.
So, see, every vaccine definitely can have side effects. The adverse effects can range from mild adverse effects to serious adverse effects. Mild adverse effects can happen in many of the patients. Just to say a simple example, sir. So recently we had this drive of BCG vaccinations. Everyone was ready to take it because they came to the home and gave it free. Many of them had problems. They had abscess formation, they had lymph node swelling formation. But they were still ready to take the vaccine, even though they had no side effects. So it is not the side effects that is preventing one from taking the vaccine, is what I think. It is the importance of the vaccine that has to be given to the people, that has to be given and incentives and then become. And every vaccine, definitely, any drug or any vaccine will have side effects. Some we have to be aware of which are important, and many of them are only mild adverse events. Very rarely serious adverse events happen in vaccine because the clinical trials also for vaccines are completely separate, and there the safety is given more important than efficacy of this.
Sir, last question. Regarding COVID vaccine, what is your comment? People are having a lot of doubts. We are hearing in public. Can you kindly clarify? Particular COVID vaccine.
So COVID vaccine, as I told, definitely, I think everyone will agree that COVID vaccine helped us in breaking the outbreak. So that was its purpose. As in everything will have mild adverse events. The important serious adverse event that we had with COVID, especially the Covishield or the AstraZeneca vaccine, is the BIT or the thrombosis, vaccine-induced idiopathic thrombosis. That was one very serious adverse event that happened in a minority of patients. Other than that, to say, any viral illness is an inflammatory condition. So any inflammatory condition will lead to some thrombotic effects as well. So if it is induced to natural infection or if it is induced through vaccine. So by giving vaccine, we are preventing the adverse events due to natural infection. So that is what has to be taken forward rather than the side effects being highlighted for the vaccine. Of course, there are side effects. There will be side effects, but we prevented them from having the natural infection, which might have been more harmful.
Last question. You mentioned about BCG vaccination, about the abscess and the patients. Actually, we have seen about 10 cases. And we sent the granulation for H2 examination. In 2 cases, it was positive for acquired cells and AIDS cells. Then I have to start the ATT once again.
So it is a natural host response with granuloma formation. So we need not start ATT. Some patients who are immunocompromised
Thank you, sir, for enlightening us with most important aspect of all the dangerous infections beforehand, especially in adults, which is often missed by most of us. Now we shall proceed to our next topic, HIV Essentials, a vital guide for every practitioner. To present this, I would like to invite Dr. R. Harikrishna Garu onto the dais.
Good morning, Manaka. I would like to invite Dr. Harikrishna Garu, MBBS, MD, Scholarship in Infectious Diseases, and and he is a leading consultant in internal medicine and infectious diseases. Prithvi Healthcare, Guntur, Andhrapradesh. His academic credentials are graduation and PG. He done his graduation, undergraduation and PG in the internal medicine in Manipal University and fellowship in infectious diseases, University of South Wales, Australia. And his expertise in tropical medicine, HIV patient, treating HIV patients, infectious disease in critical care, infectious diseases in NGDs. And he had a membership in lifetime member in CADS, lifetime member International AIDS Society, member European Society of Clinical Microbiology and Infectious Diseases, AIDS Society of India, International Diabetes Federation. He is an active participant in various research activities and speaker in national and state conference. He is an eminent physician and inspiration to many of the budding doctors.
Good morning, one and all. Thank you, Dr. Vijay, and thank you to your chairpersons. Today's my talk is going to be on HIV, which is a essential topic where every practitioner, irrespective of his specialties, will come across at some point of time, or if they see a patient who is already on treatment, comes to you for surgery or for some other modality, what shall we do? So I am going to talk very briefly and specialty specific rather than going deep into the theory part of the HIV. So my talk is going to be mostly on, is HIV still persistent in India? Is the prevalence rates are high or not? If we find HIV incidentally as a pre-op checkup, or somebody who comes with a report which was done in the periphery comes to you for treatment, or people who are already on treatment, you want to change it or you want to know whether this treatment is appropriate or not. Or for our healthcare professionals, needle prick is very common. So what to do in those cases? And now we have guidelines for PEP, what we call it as pre-exposure prep. Prep is pre-exposure prophylaxis, where one partner is negative, other partner is positive. So in those cases, how to go about? And for gynecologists, patient of HIV comes for conception and delivery, how to go about? So these are the areas which I am going to touch today. So many people ask us, is HIV, when we are discussing this topic to keep it in the sessions, is HIV still persistent in India? How many cases they are having in India? HIV is a disease which is spreading under the blanket in India in a very, very large scale. So what are the statistics? So India is among the second largest country of HIV prevalence. So we cater large number of HIV active patients who are on treatment, or the number is continuously growing. So the statistics says 15 to 49 year group people, there is 0.20 number of patients among all the male patients. And people living with HIV in India is 24.67, and that is almost 2.5 million people living. And the annual infection rate is 66,000, and people death related to HIV alone is 39,000. So this is underrated number what we generally believe, because most of the HIV deaths may not be reported as it is because of HIV. They die with various causes, and we put the cause of death in those scenarios like cancer or cardiovascular events. But the preliminary disease that is causing these events is HIV. So HIV is still a very prominent disease which we all need to understand, and which we need to see it in a bigger frame. What about us? Where are we in Andhra? Andhra stands second largest after Mumbai, after Maharashtra in HIV cases. We are seeing very fresh cases every year, every month we are seeing, we get references from various specialties of very young patients coming with HIV, young students coming with HIV. Prevalence rates are going high. We think that HIV is no more a disease of concern, but no, HIV is going high and high every year. So prevalence rates are 0.64%. 321 people officially on roll of treatment with HIV in Andhrapradesh alone. And 5,200, around 6,000 patients are newly enrolling with HIV every year in Andhrapradesh. This number may be high because most of the patients may not be enrolled into the national program. These numbers are only for those who are registered into the HIV practice or HIV care. So the numbers are very devastating with HIV. So it is time for all of us to understand what HIV is, how to control it and how to prevent it. And HIV deaths in Andhra is around 7,000. So I can put it around 10 to 12,000 cases. So WHO has come up with a program called 95, 95, 95. What this 95 says? Among all the HIV positives, at least now we know 79% are aware of their HIV. So WHO says 95% should be this number. Among all the population who are suffering with HIV, 95% should know that they are HIV positive. That is the first 95. What is second 95? Out of those 95% who knows their HIV status should be enrolled into the program. So now we have 16.8 lakh people on treatment in India. What is the third 95? Third 95 is that those who are on treatment should be virologically suppressed of HIV. So once this is planned for 2025, and we are almost reaching to this number with the help of government, private organizations, NGOs in a very big scale. Other specialists may not be knowing how much of work is going on HIV, but there is a lot of research going on HIV, which my subsequent slides I will show you. So suppose a patient comes with to a general surgeon or to any specialty for a surgical workup or for fever workup, when the patient is confirmed with HIV. So he will come and ask us what to do. So when any patient comes with HIV positive, so don't jump to the diagnosis or confirm that you are HIV positive and label him on inside that you are HIV positive. There is a lot of stigma still going on. So always confirm the HIV with either PCR or LSR. Our Western blot is the confirmatory test. It takes 24 hours to come. It is cheaper, 1,000 rupees one day. Even in Guntur we are doing very regularly. So this confirms HIV. Then if patient is affordable, go for PCR. And differentiation. We see a lot of prescriptions saying he is HIV positive. So there are two types of HIV which we need to differentiate HIV 1 and 2. The reason the prevalence rates changes, prognosis changes, treatment changes. So whenever we write HIV, please write HIV 1 or 2 for the sake of treatment. Just don't write RBD positive. Try to find out whether he is HIV 1 positive or HIV 2 positive. Once the HIV is confirmed, for all these patients, these are the baseline tests which we need to get it done before enrolling them into HIV treatment program. So basic tests will tell us is there any opportunistic infections or already established complications in these patients or not. Once we get the baseline test done, then as I told you, why do we need to differentiate HIV 1 and 2? Prevalence varies from 1 to 2. 2 is less common. 90% of patients suffer from HIV 1, 5% HIV 2. We see 3 to 5% with both HIV 1 and 2. Treatment varies in 3 different group of people. Transmission rate changes. When we see a HIV 1 patient, we counsel them differently. When we see HIV 2 patients, we counsel them in a different way. Progression will also change and treatment also changes. So this is the graph, this is the tabular form where we can how to go about when we diagnose a patient with HIV. This is a brief thing which you can take a photograph. I can run through when patient is diagnosed with HIV. After ART initiation, modification, get a CD4 done, viral load, genotyping, or we call it as DST, drug sensitivity testing, just like cultures. We see whether this patient is sensitive or not to the group of drug which is very specific or what we are going to use. So this we generally do it patients who are already on treatment, not responding, virological failure or immunological failure. We want to change the regimens, we generally do DSTs, and which is readily available in Guntur. And the criteria to get the DST is that viral load should be more than 5,000 and it takes around 1 week to come. So when you are planning to change the regimens, get a DST done, it costs around 10,000 rupees. And all the other viral screenings, LFTs, to check for the toxicity secondary to HIV are the drugs which you are going to change. And when we diagnose the patient, the first question he will ask is that what stage I am? How to tell the patient that which stage of the HIV he is on, and how to handle him and how to push him to the program very effectively. CD4, simple thing, CD4 count more than 500 is asymptomatic. Most of the times we don't pick this patient at stage 1 unless we are doing a screening or patient is going for blood donation or some other accidental findings or patient going for a pre-op workup, we find this patient. Stage 2, 350 to 449, this is the stage where we generally pick up the patients with unknown fever, simple weight loss, loss of appetite. Stage 3 is where all of us will pick up the case. These patients most likely come with persistent diarrhea. Oral candidiasis is one very catchy thing to pick up the patients. always ask the patient to show his tongue. So when you find oral candidiasis, until proved otherwise, we can go for HIV testing. And most of the patients will come positive if it is HIV positive in the early stages. And pulmonary tuberculosis is another entity. All of us will treat tuberculosis to some or other organ. Ophthalmologists will treat chronic uveitis, pulmonologists will treat lung, gynecologists will treat tubular tuberculosis. So any patient who comes with tuberculosis, even before you start the treatment, try to get HIV testing done and find out whether it is HIV 1 or 2 before you start ADT. Then stage 4, this is the stage where we generally come up with patients with cancer and HIV encephalopathy. Patient is throwing seizure and CD4 is very low, less than 200. So once you find this staging, it is very easy to counsel the patient how to go about it in treatment modifications. So this is how generally HIV goes. Initial weeks to months, where what we call it as window period, where HIV may not be very prominently affecting the body. Then slowly it invades the CD4 cells over a period of months, years. Then it completely invades the CD4, and we see lesser CD4 count. When to start with ART? Suppose patient we are diagnosed. Either you refer the patient or you may start treating the patient. After this session, you may start treating the patient with basic information also. So when to start patient? When to start ART? What are the guidelines says? Guidelines says test and treat. Any patient who is detected with HIV, start treatment irrespective of CD4 count, irrespective of viral load. So whenever we see a patient with HIV, earlier days, the guidelines were saying you start it when it is 350, less than 400, our patient is symptomatic. Now the guidelines says test and treat. As soon as the patient is fine HIV, confirm the HIV status with either Western blot or PCR, then go for treatment. So why do you, before going to start the treatment, why do you buy some time? We generally buy some time. We have a lot of experiences with young people coming with HIV incidentally found. So we don't start the treatment, we buy some time to counsel them. Counseling is very, very important. We have so bad pathologic experiences. The moment we say HIV positive, we will go out and commit suicide. And family comes back and asks us, this patient has come to your hospital, what happened, what have you told, and this patient committed suicide. We have many pathologic such stories with HIV patients who are diagnosed in a very young stage. So don't jump to the conclusion, break the bad news slowly. We buy time. Initially what we say it is positive, but we will reconfirm it, we will take time, come back with PCR report or Western blot, so he will slowly get convinced himself, 50% he will be convinced. So the Western blot comes, then again we will counsel the patient saying that your Western blot is also positive, but don't worry, we will get the CD4 and see which stage you are in. Again after 3 days we counsel the patient. Then patient comes with CD4 and viral load. Then we'll say your CD4 is 400, don't worry, your viral load is so less, so you don't need to worry. So breaking the bad news in HIV is very, very significant, and deaths we see so pathetic that many young girls, young students who comes with HIV positive, maybe through parents or through transmission in other sources, but please don't reveal the HIV status upfront in a deliberate way. So try to counsel the patient, which is very important. So why do we want to treat the patient? What is the necessity to treat the patient? When HIV CD4 is 500, viral load is low, why do we need to treat the patient? So the treatment should be focused on 4 points. Clinical response, virological response, immunological response, therapeutic goals and preventive goals. Clinical goals, we need to see that patient is clinically improved. Virological response, his viral load, CD4 count should be more than 500. Immunological response, his viral load should be less than detectable. Therapeutic goals, are we treating with the right drug, are we treating with the right dose, and patient is adherent to the treatment, no toxicities, and is tolerating well with the treatment. Preventive goals, he should not contaminate to the society, he should not contaminate to the partner, he should not contaminate to his child. So these are the primary goals of treatment. So what to start? There are so many guidelines, and all guidelines in 2024. So this is brief chart of various group of drugs. Now we have 4 active group of drugs which we are using for HIV, and all the national programs have come up with combination drugs with 1 single pill per day, which is more than sufficient. The combination pill which we are using now is called as DLT, Dolutegravir, lamivudine and tenofovir, which is available even in government and in private sector, which is easily available, very efficient and low cost. It costs around 2,500 to 3,000 rupees. So that can be considered as a first line drug. So first line drug, these are the recommendations for the different age groups and different populations, adult and adolescent, pregnant female, infant, children. So we have different guidelines for different patients. So stick to the guidelines, stick to the formulations. They are single drug single dose regimens. So they are very effective in the present era. So the newer guidelines says that you don't need to go for 3 drug regimens. We have 2 drug regimens now. We have long-acting drugs coming on the way. FDA have approved different combinations for 2 drug regimens. Now the world is moving towards long-actings. Whether you take psychiatry, whether you take dermatology, whether you take general medicine, whether you take diabetes, the world is moving towards long-acting drugs. So as with HIV. Even in HIV, we have long-acting drugs which are already approved. We can have Cardio-renal with ritonavir, which is once in 2 months in an IM preparation, which has been approved. And now in the pipeline, in another 3-4 months, there are another group of drugs which are already approved coming to India, which I can discuss. This is the 2 drug combinations. We can take once in 2 months, intravascular form. This is already approved, which is being approved for PEP as well as maintenance therapy. Patient comes to HIV clinics, take the IM injection once in 2 months and goes off. This is the IM, how we use it. And this is the newer drug which has been newly launched in India, which we can use it once in 6 months intravascular injection. This can be given along with already existing HIV medication, or we can slowly switch over the patient from the oral form to the intravascular once in 6 months injection. Maybe by 2025 end, India will have this molecule. You can tell, most of our patients will come and ask, sir, do I need to take medication for lifetime? Do I need to take tablet for lifetime? I am having a lot of toxicities. I have a lot of stigma. Wherever I go, I have to take this medication like diabetes. So these are the things which are going to answer all the patients' compliances. So compliance is one of the biggest issue in HIV. So these kind of medications will change the HIV outlook. So toxicities doesn't permit. So opportunistic infections. If you see this graph, I can see this is all specialty driven. Tuberculosis, chest physicians will see. Oral candidiasis, dermatologists will see. Diarrhea, gastros will see. Herpes, again, dermatologists will see. Cryptococcal meningitis, neurologists. CMV retinitis, ophthalmologists. Bacterial pneumonia, respiratory. So HIV is one disease which affects entire medical branches. So every department will come across HIV in some or other form, and we need to be cautious that any of these patients come to us, please get a HIV test done. So HIV is not only the disease of general medicine or ID, HIV is disease of all the branches, which we should know the basics about it. So TB, all the specialties will be treating TB. And all the patients who are on TB, as I have told, need to be checked for HIV status. So patients who are already on HIV gets a tuberculosis, there are different guidelines. Patients whom we find tuberculosis and HIV both together simultaneously, we have to wait for at least 2 to 4 weeks before we start the HIV treatment to avoid IVs. Or if the patient is critically ill, neurological symptoms or any other critically important symptoms, then take 1 week time, start ART and ADT simultaneously. Don't wait too much time. Vaccines, as Dr. Niren was talking about vaccine. Vaccine plays a crucial role in all our HIV patients. As a key population, HIV also comes into the key population, where we generally recommend our patients to go with as many vaccinations as possible. This will cut down the subsequent infection, cut down in the hospitalizations and deaths. So vaccination plays a very crucial role. How to prevent? PrEP. Now we have a lot of guidelines where we can give the patient a monthly tablet, where when one partner is negative, one partner is positive, we can go for PrEP. Andhrapradesh is the first state to start PrEP with the association with government, a program called as PrEP. Then post-exposure prophylaxis or needle prick, which everybody will come across. We get a lot of phone calls saying that I had a needle prick of HIV patient when I was operating, what to do. So 72 hours, start the treatment, get the test done, even if it is negative, go for treatment, check every 6 weeks, then 3 months and 6 months with ELISA or Western. Once it is negative, then you are considered as negative. Minimum treatment should be taken for 28 weeks. So this is for the gynecologist. U is equal to U. Now we have a session, end of these complete sessions, that U is equal to U, a short film is going to be broadcasted end of the conference. So HIV positive mother can conceive, HIV positive father, HIV negative mother can conceive, the child can deliver a negative child. So when the viral load is 0, they can have an unprotected sex also, and they can conceive a negative child. Now we have reached a phase, it is almost getting eradicated. So comfortably gynecologists will go ahead if they find a partner HIV positive and one partner HIV negative, they can confidently tell that go for conception and childbirth. These are few modalities. So when to refer a patient? Any toxic situation, don't wait. HIV patients will react in a more aggressive way, deteriorate very faster. Don't wait till further more symptoms comes, or if the patient develops any more complications. As soon as you see these symptoms, refer to IMA. Thank you. I'm on time.
Thank you, sir. Thank you very much. Sir, 2 minutes, can everybody stand up? This is the antibiotic awareness, antibiotic resistance awareness week. I think most of you have received this pamphlet, it is there with you. Please repeat this from me. Most of the people got it. Yeah, you repeat this, please. I recognize that antimicrobial resistance is a public health priority. Please repeat. At a global and national level. And for medical professionals. As a dedicated practitioner of modern medicine. I commit to uphold the sanctity of my profession. By prescribing antimicrobials judiciously. With integrity and care. And with each prescription. I commit to assess thoroughly. Ensuring antimicrobials are used. Only when truly necessary. I commit to balance the benefit and risks. Considering patient health. As well as public safety. I commit to choose antimicrobial wisely. Guided by evidence. Stewardship practices. And the specific needs of my patient. I commit to defend. Against antimicrobial resistance. Preserving the power of antibiotics. For the further generations. Together, let us action contribute to health. And happiness of all. Free from shadow of AMR. Thank you. Not only repeating, please try to follow it. Antimicrobial resistance. Thank you very much.
Now, thank you, sir. Thank you, Krishna, sir, for your enlightening discussion.
I will request chairpersons to please felicitate the speakers.
A small announcement regarding the quiz. So, at the end of each session, we will have a quiz, which is an online quiz. So, to participate in the quiz, you have to scan the QR code on the delegate tag. Once you scan the QR code, click on the quiz button. Questions will be displayed after each session for only 6 minutes. Click on the right answer and then submit your answers. Quiz winners will be awarded attractive prizes, so pick up your mobiles and scan the QR code on your delegate tags.
To preserve our ethnicity, we are felicitating our guests with Mangalwari Pattu shawls. We request Dr. M. Hanmantarao Garu, Senior Pediatrician from Chirikluppet, to please come on to the dais and felicitate our chairpersons. Dark pathway and how to come over it. So, to chair this session, I would like to invite Dr. G. Sivaram Krishna Garu, MD/DM, in charge HOD Nephrology Department, GGH Guntur. Next, I would like to invite Dr. G. Vanajakshama Garu, MD/DM, Professor in Cardiology, SWIMS, Tirupati. Ma'am, sir, we invite you onto the dais. Moving on to the topic of this session, tackling high glucose, weight and CVS with GLP-1 analogs and other newer anti-diabetic agents by Dr. Kongal Srikanth Garu. Sir, we welcome you onto the dais.
Welcome all. Dr. Kongal Srikanth Garu is an endocrinologist and one of the senior most endocrinologists in Guntur city with around 15 to 20 years of experience. And he is my classmate and alumnus of Guntur Medical College of 1992 batch. And he did his MD General Medicine from AIMS, New Delhi, and DM Endocrinology from SCBJ Lucknow. He has very much interested in publications and research activities. Today he is going to talk about glucagon-like peptide 1 agonist, which is a new group of drugs, especially semaglutide, which is a good anti-diabetic drug and also used in obesity. Without much wasting time, I hand over the mic to Dr. Srikanth, and please go ahead.
Good morning, everyone. I would like to thank IMA for giving this opportunity. So, without wasting much time, we'll move on to the topic. And we all know, as it has been introduced, these are the new molecules, GLP-1 analogs, which are one of the greatest inventions of 21st century. And they are doing wonders. Of course, they are not very widely launched in India. We are not yet experienced well, but they are going to make a great way into our lives, into our practices in managing obesity and diabetes. So these are the drugs. Anyway, I'll cover them in the future slides, and I'll start with a case. So which has given a kind of aha experience for me also as a endocrinologist practicing with conventional anti-diabetic drugs. So there is a 50-year-old male patient who is type 2 diabetes, presented with uncontrolled sugars in the range of 360 and 540 with an A1C of 11.4 with a BMI of 25 only. So on multiple OHAs including DPP-4 inhibitors with no control. So creatinine was 1.4 and the diabetic retinopathy was there. It is a severe non-proliferative diabetic retinopathy. Nephropathy is also there with microalbuminuria in the range of 1300 milligrams per creatinine ratio. And as a part of the trial recruitment, I have been one of the primary investigators in a focus trial, which is a global multicentric trial, which is happening across the globe in several countries with semaglutide, which is the leading anti-diabetic drug with the GLP-1 class. So started the drug as a part of it because the patient is fitting all the inclusion criteria. We have screened him and he became eligible, and we started the treatment with semaglutide initially with 0.25, and within 1 month, without much any side effects, it's a good control of sugars in the range of 150 and 220. It's a randomized control trial with 1:1 ratio of active and placebo. So we don't know in the initial stage whether they got the placebo or the active drug. So we continued all the other drugs. So dose increased in the next month to 0.5, and the sugars have come down further 90 to 120 milligrams per deciliter. And after the end of second month, we started complaining of hypoglycemia. So gradually we stopped or decreased the dose of sulfonylurea from high doses to gradually in 3-4 months time we stopped sulfonylureas including DPP-4 inhibitors. So after 6 months, the sugars are completely controlled. A1C is 6.8, is only on metformin and some other single drug with a good diet and exercise. Improved and stable retinopathy was also there. Initially he had macular edema, which has improved with diabetes control and the local treatment also. Nephropathy also improved and stable, and I have been managing these patients with semaglutide for the last 2 years, and A1C is ever since very stable. Initially he couldn't tolerate. We are supposed to go to 1 mg, but with 0.5 mg itself he has got excellent control. So after that, the same trial we continued. Globally it is around 1467 patients. India we have screened around 230 patients randomized. We have screened almost 75 patients at Endolife Hospital and randomized almost 54 patients into this trial. This is one of the highest single center recruitment across the globe. It's a very good trial to look at the retinopathy outcomes after starting semaglutide. So usually for antibiotic drugs they use CVOT trials and nephropathy trials, but this is one of the rare occasions where retinopathy screening outcome trial is also being planned. It's an ongoing trial, another 3 years for the trial completion. But what I realized was, in these 54 patients, half of them are placebos and half of them are active drugs. And apart from the kind of experience with the first case, several cases, some patients could not tolerate the drug well, then some patient tolerated full dose, but there was no side effects and good control, and some patients partial control. Everything happens with this, so we need to understand these drugs well. Then only we can use them judiciously in our practices. So what is GLP-1? It is a glucagon-like peptide. It's a 30 amino acids, 31 amino acids peptide secreted from the distal gut. So on stimulation with insulin, glucose, it is secreted. It is an incretin hormone. Why it has come into the picture of diabetes practices, there is a defect of these are incretin hormones secreted by the enteroendocrine cells of the gut. They augment the insulin response when a glucose load is given orally, not intravenously. So it means that there is a drug between glucose and insulin. There is a hormone between glucose and insulin, a carbohydrate load and insulin, secreted from the gut, which increases the response of the pancreatic beta cells to insulin. So these are two molecules. One is GLP-1 and the other is gastric inhibitory peptide, the GIP. One is secreted from the proximal gut, the other is secreted from the distal gut. Both of them together are secreted, and ever since this physiological finding has been identified, it has been well investigated. The native GLP-1 molecule, which has got half-life of only 1 to 2 minutes. So then it has been realized that GLP-1 increases insulin secretion, also increases insulin synthesis, beta cell neogenesis, beta cell proliferation, and also increases beta cell mass, and increases beta cell apoptosis, and also suppresses the glucagon secretion, which is more in type 2 diabetic patients. Apart from the beta cell effects and alpha cell effect, it also acts at the level of hypothalamus, promoting satiety and decreasing hunger, and also decreases hepatic glucose production, increases the glucose uptake, and CV protective effects, gastric motility is also slowed down, acid secretion is also decreased. So it has a multifactorial addressing of the pathophysiology in diabetic patients. So let us see in this cartoon how liraglutide acts in a beta cell. Usually when the glucose is present and such increased in circulation, it is transported into the beta cell with blood through and increases the insulin secretion. But the new mechanism, the liraglutide, once it is bound to GLP-1 receptors on the surface of the beta cell, it augments the response of beta cells to when the glucose load is increased or in the circulatory glucose increases, augmented insulin response, which is an appropriate insulin response. Unlike sulfonylureas insulin where we give that unregulatedly, it is a regulated and increased insulin secretion without causing hypoglycemia. Actually, it came into the diabetic practice as a replacement for sulfonylurea, not producing hypoglycemia and controlling diabetes. So, but in the years which has been investigated thoroughly, it was proven to have multiple effects on almost like 5 to 6 pathophysiological effects in diabetic patients. So I don't go into the details, whether it is pancreatic or whether it is at the hypothalamus level, incretin effects, everything is corrected. Apart from 3 pathophysiological mechanisms, almost like 5 to 6 mechanisms were directly or indirectly improved in a favorable way to control the diabetes. So when you understand, I would like, apart from the drug is over, so we know that type 2 diabetes, obesity, they are at the surface looks different, but underlying pathophysiology in many of them it is similar. They increase insulin resistance, hyperglycemia may be there in few, systemic inflammation is activated, lipid metabolism goes haywire with LDLs and TGs going high, and also endothelial dysfunction, platelet dysfunction, hypertension, everything happens in all of them, ultimately leading to a prothrombotic and vulnerable blood vessels with the CVD risk. So they are all intertwined. Previously we were managing them independently. Obesity was only being addressed with diet and exercise, not much of medical agents, but now we have very good agents which can address all of them together. So previously we were addressing all the risk factors separately, but with these modern drugs like SGLT and GLP-1 analogs, we are addressing simultaneously all the risk factors. When we start GLP-1 analogs, we get a reduction in A1C, we get a reduction of body weight, blood pressure is also reduced, inflammatory markers are also reduced, CV benefits are also being proven. So previously the guidelines used to be in a different way. So it is based on blood sugar and HbA1c. You start one drug, you don't get control, then you start another drug like that. But in today's day, the guidelines are all totally changing. So the evidence is also coming totally different. We divide the patients into groups like a diabetic patient, long-standing with CVD, with the risk of CKD, with the risk of heart failure, with the risk of obesity with this thing. Maybe diabetic patient with OSA, diabetic patient with OA. That way the classifications is happening. And when you have two risk factors based on the evidence, these drugs are coming in a very early stage. So started in the late diabetic spectrum, now we are starting them much early in the natural course of the disease. So in all high-risk cases for ASCVD and CKD and obesity with diabetes, these are the drugs of choice as per all the guidelines along with SGLT inhibitors. Obesity, diabetes and CVD, they are all highly intertwined. If you see in our practices, you have some patients where all the three are there. We have some patients where obesity, diabetes are together, and some patients who have diabetes and CVD or CVD and obesity. They are all intertwined. So in various proportions they may have together, and some patients who may have all of them together. So we have to address all of them together in due course of time as we want, not just controlling two numbers in diabetic practice as it used to be previously. Nowadays we are addressing simultaneously all of things. So what are the GLP-1 analogs which are there in the market? So coming to the concept, there are two groups. One is extendin-based therapies, which are Gila monster related. Extendin 4 is the basic molecule. Only one molecule is active in the market, that is lixisenatide, which is predominantly marketed for postprandial glucose control, and it is not very well favored, only in some patients who use, and marketed by Sanofi along with the insulin glargine as a combined molecule. Coming to the other four drugs, one is dulaglutide, the other is liraglutide, semaglutide and semaglutide oral also. These are the four molecules actively available in India. Semaglutide injectable is not yet available. Maybe by June 2025 it may be launched. But the oral drug is available. And dulaglutide, I will go into the details of that in the future slides. It's a weekly once molecule. Liraglutide is a daily molecule. Semaglutide is again weekly once injectable. Oral semaglutide is a daily molecule which is available regularly in our pharmacies, and it is also creeping into this thing. So the difference, you must be wondering how a peptide molecule is being given orally. So there is a good innovation in the form of this SNAC, which is an absorption enhancer. Okay, when you give this molecule along with this semaglutide. Semaglutide is nothing but a GLP-1 native molecule with 3 amino acids changed, and to which one fatty acid is also attached. So when you give this molecule as a co-formulation, it increases the absorption of this peptide molecule from the stomach wall in a good proportion. That is 1% absorption only happens. Approximately only 1% of semaglutide is absorbed, and the rest is secreted in the GIT. So we give 3, 7 and 14 mg, but of which over 7 days which we give, only 1% of the entire dose may be absorbed, but that itself is sufficient. If you have a semaglutide of 0.5 mg or 1 mg also, it does all the wonders which is supposed to get. So even 1% absorption is also sufficient enough. So these are the entire pioneer clinical trial program evaluating the efficacy of oral semaglutide in various conditions, against placebo, against SGLT inhibitors, against insulin, against other DPP-4 inhibitors, and also in renal impairment patients in CVOT trials. Ultimately, it has been proven as one of the very superior anti-diabetic drugs with a HbA1c reduction of 1.5% in majority of the trials, up to 1.5. Not everybody loses the same. The higher the A1c, the higher the A1c reduction. And it is from 0.8 to 1.5, irrespective of whatever drugs they are on, including even if they are on insulin, it produces some amount of HbA1c reduction, and also they produce a good amount of weight loss. Usually we have 3 classes of drugs. One are weight neutral drugs, the other are weight increasing drugs like sulfonylureas and insulins, and these are the drugs which are decreasing the weight also, particularly in obese patients. They reduce almost to the tune of 5 kg weight reduction, and in CVOT also has been proven, and it also reduces the waist circumference in majority of the cases. AMPA also decreases waist circumference because it also leads to reduction in the weight. And it also decreases hunger suppression, causes 35% reduction in the energy intake in this subset of patients. It also reduces the systolic blood pressure, improves the LDL, improves the triglycerides, and also reduces the vascular inflammation in the form of CRP reduction in all the long-standing CVD and CKD patients. And also A lot of mechanistic benefits are seen, whatever I have told you till now to this thing. And if they are not able to produce some benefit, if you add SGLT inhibitors to the same group of patients, we can give a combination therapy, and it produces a lot of metabolic, renal and cardiovascular benefits which are synergistic. This combination is going to be more and more synergistic and produces even more benefits. So definitely, it's a universal recommendation from all the guidelines to use the combination of both GLP-1 analogs as well as SGLT2 inhibitors. So I'm not going to details, benefits are definitely going to be there. So with this background, I would like to go on to the next case, that is another case which is more in the non-diabetic space, that is obesity. Is another step 1 trial, which is the trial based on which FDA has given the approval for obesity program. Though it has been started semaglutide as an anti-diabetic drug, surprisingly it became an anti-obesity drug. He is the first gentleman. I have been a part of this step 1 trial way back in 2018. We have recruited around 22 patients. It's the case of BMI 38 obese person with a weight of 110 kg and a height of 1.7 meters with severe obstructive sleep apnea with severe insulin resistance, but he doesn't have diabetes. So we recruited into this trial of semaglutide with step 1, started with 2.25. Here the dose of semaglutide in diabetes is up to 1 mg, but here we can go up to 2.4 mg. It's titrated to 2.4 mg. He, apart from some initial GI side effects, nausea, vomiting and some vomiting and diarrhea, but he tolerated well and he reached 2.4. At the end of 68 weeks, he lost almost 26 kgs, which is one of the highest weight loss, 24% weight loss. So hypertension gone, OS improved, symptomatically much better. In the same way, we had similar experience in that 22 patients. Half of them are almost like 30-35% are placebo. Rest of the patients we have very good outcome. Not everybody had got 24%. Average is only around 15-16% weight loss. But rest of the patients, some patients did not tolerate, some patients lost almost like 10%, something like that. So there was a confusion. Why and how an insulin promoting or stimulating drug is causing weight loss, which is contrary to our previous beliefs. But what is happening is it acts at the level of hypothalamus, that is arcuate nucleus, and both orexigenic neurons as well as anorexigenic neurons, and produces a good amount of hunger suppression, which is a very dominant effect and a higher doses. So the effect of insulin stimulation goes down and it dominates, and the patient produces very severe suppression of hunger, and also absorption is decreased and delayed gastric emptying happens. Because of that, it produces a significant amount of weight loss. So what is the experience with the molecules available? Liraglutide is the first approved for weight management by FDA. It's a mean weight loss of around 5.6 kg in 3 mg liraglutide. But in India at that time when liraglutide was available with Victoza, the cost of 3 mg used to be 30,000. So we never used to really use it because of the expenses. And 63% only lost 5% of weight loss and 33% lost more than 10%. So when a semaglutide was tried, it is not 5%, but it is 14.9 to 15.8% weight loss after 68 weeks in various step trial programs. It's a very successful molecule. The success, I can tell you, it is one of the biggest invention of the century, and Novo Nordisk has been present for 100 years from 1921 to almost like 2021. What it made in the last 1 year, 100 years, it made in the last 3 years with this invention of semaglutide across the globe, and one of the leading company in the Europe also. With this, another company, Eli Lilly, has developed another very innovative molecule, which is not just alone a GLP-1 analog. It combined both GLP and GIP. These are two ingredients which are available in our body, both from foregut and intestine. They combined it into a single molecule peptide, which is working for 7 days. This is once weekly and more successful than semaglutide. 5 mg at 72 weeks produced 15% weight loss, and 10 mg at 72 weeks leads to 19.5% of the weight loss, and 15 mg has produced almost like 20.9% of weight loss. So 60% of all the patients who have used 15 mg have developed lost more than 20% weight loss. Launched in USA, may be launched in India in June 2025. in the name of Monjiro. It is already it is available in the black market in India to the tune of 100 crores, and it costs almost like 76,000 in the black market every month. So with this, two basic drugs which are available in the US market, the several drugs are in pipeline. GLP-1 is also being combined with amylin. Amylin is another allopancreatic cells, and cardio-renal is a once a weekly amylin analog, more effective on hunger and satiety. But when it is used alone, it produces only 10% weight loss. So what Novo Nordisk did is they combined cagrilintide and semaglutide in the combination of 1:1, 2.4 NT and 2.4 NT, the same solution, and it worked as a synergistic combination. And it's a redefined program is going on. 1, 2, 3 and trials are going on. 1 and 2 are addressing obesity and diabetes separately. And we are part of the redefined 3 trial, which is the CVOT trial. And the expected weight loss with this combination is almost like 20 to 25% in obese patients. It is also a next generation molecule which may replace semaglutide in due course of time. And with this basic innovation, Lilly has developed another molecule by name GGG analog, which is a GLP-1, GIP and glucagon. All the 3 peptides are combined into one molecule and it acts once a week, which is even more synergistic combination. One of the most successful molecule in pipeline to date in development. So phase 2 trials have given an AHA results and kind of NEJM, it was 2023 published. 1 mg leads to around 8.7% weight loss, and 4 mg 17, 8 mg 22%, and 12 mg is 24.2%. And this is only phase 2. It is given for only 6 months time. One trial program is going on at our hospital. We have recruited almost like 33 patients, and the results are excellent. It is one of the very effective drugs. One of my patients lost almost like 40% weight loss. It is never seen with any kind of, apart from diabetic surgery. And the expectation is that this drug is going to replace bariatric surgery and it may become obsolete also. That is the kind of power of the drug. It is called GGG analog. The name of the drug is retatrutide and by Lilly. It is being investigated for OSA, even osteoarthritis and CVD risk and PCO, all other areas also being investigated. Another drug by name orforglipron, which is a non-peptide GLP-1 analog. Traditional belief is that GLP-1 is a peptide and GLP-1 receptor only responds to peptide, but Lilly somehow biotechnologically marveled and invented a drug which binds to a peptide receptor and stimulates in a very systematic way. It can be given orally once a day, appears to be very effective comparable to injectable semaglutide, and Attain-1 is the clinical trial program which is going on globally. We have recruited around 23 patients in it. It also appears to be on par with semaglutide and doing very good results. Attain OSA program also is being investigated. We are part of the trial locally. And another drug by name amycretin, which is a combined analog in a single molecule of GLP-1 and amylin, weekly once, and oral analog is also planned, appears to be effective, and AMAZE trial program is being launched next year. So these are all not, they are all in development and they are going to be launched in maybe due course of time in 3 to 4 years of time. So having understood the importance of all these molecules with various peptide combinations producing so great results, they are going to be integrated. So what are the possibilities in India with GLP-1 as of today? Oral semaglutide is available in the name of Ribelsus, 3 mg, 7 mg and 14 mg. It has to be given once a day in the morning in the fasting state before you take anything. Only with a 50 to 100 ml of water you should take, not with a liter of water or something. And you should not eat for 45 minutes at least in order to get that 1% absorption of the drug. So you may start with 3 and see where the patient tolerates and you can continue the drug accordingly. Injectable gelaglutide by name Aplivent and Trulicity available in 0.75 and 1.5 mg. It can be used not in obesity but in diabetic patients very effectively. Wherever patient feels convenience of taking weekly once injection, you can try this. Both Ribelsus and Aplivent Trulicity are costing in the range of 10,000 rupees a month. Injectable liraglutide recently biosimilar has been launched by Glenmark and Ares. And they are also working well. It is for the tune of 2,000 to 4,000 or 5,000 rupees a month, and it is also working wonders. And it is a daily injectable molecule. For most of our middle class patients, we can try this whenever the other drugs fail. Injection liraglutide is also coming with in combination with insulin for particular patients like Zoltofy and Soliqua, where liraglutide is combined with insulin degludec by Novo Nordisk, and other drug lixisenatide is combined with Glargine by Sanofi. It's also available in the market. We can use them. In future, next year we may get launch of semaglutide in June 2025. Tirzepatide also may be launched in 2025. These are the other molecules and pipeline. I didn't cover how they act, but they are all basically GLP plus associated peptide analogs. And here are the various clinical trial programs which we have conducted at Endolife Hospital, almost like more than all new molecules we are testing, and we had a very wonderful fascinating journey without wasting much time. Does a beautiful job. Otherwise, you will have either combination or you spend so much but the effect will not come. So that is the reason why you have to choose them well. Monitor for the side effects and manage. Pancreatitis and GX effects are real side effects, but you have to monitor frequently with amylase, lipase, and even sometimes calcitonin to prevent the onset of other complications. With this, I would like to end. I hope I stick to my time. Thank you.
Any one or two questions? Interesting topic. One or two questions.
So regarding the obesity management, once the patient receives ideal once patient achieves ideal BMI, can we stop the drugs or are there any chances of
actually, it can be. It is a mixed response. So ideally speaking, it has to be continued, but we can down titrate the dose to the level of hunger suppression. So, and then maintain with a good improved, lifestyle management. Actually, what happens is if the patient is BMI of 30, 35 or 40, their ability to do a lot of lifestyle modification is difficult. So, you start with the pharmacotherapy and aggressive diet. Once the patient loses, his general condition and quality of life improves. And it's a long-term journey. You have to, in 1 year time or 2 year time, improve his physical fitness and try to maintain that physical activity and behavior modification as much as possible. And even if you stop, if they are maintaining, it is fine. If they are not able to maintain, you can continue a low dose of GLP-1 analogs and continue.
What is the FDA approved dose of semaglutide?
Semaglutide for obesity management, approved dose is 2.4 mg. 2.4 mg. And oral semaglutide is not approved. So injectable semaglutide only is approved for obesity. Oral semaglutide only for diabetes. And diabetes management, semaglutide approved dose is 1 mg.
No questions, we will conclude the session. Thank you very much.
Thank you, sir, for making it so simple and clear, in spite of going into the depth of the management and with multiple carry-home messages. Now we shall proceed to a feast of panel discussion, which enlightens us on the interconnection between obesity, heart, and kidney, and how to handle them collectively for better results. I invite Dr. C.H. Ramakrishna Garu, MD DM Nephrology, and take over the panel discussion.
For this panel discussion, I invite Dr. C.H. Ramakrishna, nephrologist, founder of Vedanta Hospitals and Hello Kidney, and he is a student of SWIMS Nephrology Department. And next, I invite Dr. B. Paraya Chaudhary, cardiologist at Guntur, and he received FSCC in 2014. Invite Dr. Murali, endocrinologist from Vijayawada, for this panel discussion. The topic for the discussion is How do you treat me? I am an obese diabetic spilling albumin with regional wall motion abnormalities.
Very good morning, my teachers, seniors, friends, and colleagues. I thank Dr. Manujakshi Madam for her kind introduction because she was known to me well when I was doing my nephrology graduation in Tirupati, and also thank Dr. Shivram also. And I must thank the organizers for conducting this beautiful, fantastic conference because it is on par with any national conference. I must thank Dr. Harita and Nanda's team. And I am privileged to have Dr. Parajali sir and also Dr. Murali, endocrine from practicing in Vijayawada, coming from London, to share this knowledge sharing session. Today we are going to discuss about a global health challenge which is in the continuation of how Dr. Shrikant has been elaborating us in the previous lecture. So we see a lot of this kind of patients, this multi-morbid, comorbid issue patient with diabetes, hypertension, obesity, with having mild albuminuria and instantly detected regional wall motion abnormalities. Because these kind of patients, they don't come to you, whether it's a medical expertise or surgical specialist, they don't come initially with cardiac event or a renal event. You will see these patients from maybe because of a small febrile illness to an advanced cancer also. But when you dig into the in-depth of this patient clinical history evaluation, you will find these abnormalities. But we tend to neglect it very easily because it doesn't matter to us most of the times. We have chosen this topic because across the world, about every year, 50 to 60 million people are dying because of cardiovascular renal events contributed by heart and kidney related deaths only. And probably all tertiary care hospitals across the world are flourishing because of outpatient and inpatient hospital admissions because of this diabetes, hypertension, cardiovascular or kidney related hospitalizations only. And obviously, a single admissions of these patients we will make them bankruptcy because of huge healthcare expenditure. And a lot of things have been happening for the past 10 years to understand the science and biology of this entire disease spectrum. And not only that, many doctors are also not safe because of these cardiovascular renal events. In the last, the recently article coming in the English newspaper, in a government hospital, when they evaluated about 500 doctors, 53% were found to have diabetes and 24% were found to be hypertensive. So obviously they tend to develop cardiovascular renal manifestations in their lifetime. So it's not a didactic lecture. We wanted to make this an interactive knowledge sharing session with the help of endocrine and cardiologists. So this is a thematic case example that we see routinely in our practice. Maybe primary physician to an oncologist or a cardiologist or a physician. So we have here a middle-aged diabetic obese marketing guy, Mr. Kumar with 40 years of age, and he is having BMI of about 32. He visited a physician and with history of 5 years of diabetes and 2 years of hypertension. Physician is the intelligent guy enough to see that with 5 years history of diabetes, he has been put on insulin and oral drugs, indicating that his beta cells are lost, maybe with patient having higher insulin resistance, and he wants to do a comprehensive health assessment without any symptoms. On health assessment, he was found to have this creatinine of about 1.7 milligrams and GFR about 50 ml per minute. And his urinary albuminuria is about 1.5 grams per gram of creatinine. And when he found to be having ECG, having about QS complexes in inferior ribs, and then the RWMA, regional wall abnormalities, were found in the inferior aspect of cardiac muscle, along with dyslipidemia and diabetic retinopathy. So the diagnosis is diabetic kidney disease with stage 3A, A3, coronary artery disease, diabetes mellitus, hypertension, obesity, and dyslipidemia. Generally, when we see these kind of patients, the objective of treatment is to give a lead and lead a life equal to any other healthy person, reverse and prevent kidney failure, avoid an adverse cardiac event with a healthy metabolism. So we have a middle-aged diabetic patient with CKD stage 3. So first thing when you see a patient like this is understand the disease and stage this patient at what stage of CKD the patient has. Everybody, we routinely evaluate every patient whether he comes with a fever or an advanced cancer. We routinely perform urine analysis and blood investigations. With these two markers, you can diagnose CKD. One is blood marker with serum creatinine estimation and measuring EGFR out of CKD APA 2021 formula and estimating urinary albumin creatinine ratio. Very easy and it doesn't cost us much also. But what we miss is estimating EGFR will not be done 99% of times to a patient, which is probably one of the reasons why we neglect underlying silent CKD in a patient. CKD in a multimorbid patient is not a simple bystander, it is a disease multiplier. So this patient has CKD stage G3A and proteinuria of more than 300 milligrams. What happens when we do not see and act now? So generally in 2000 because last 10 years, because of widespread adoption of electronic health records and EMRs, quality data has been captured across the hospitals in Europe and in America. Though we have patient volumes, we could not access the patient's data, but we still utilize some of the risk prediction models. Previously, when you see a patient like this, we just wait and watch whether the patient going into kidney failure or an adverse cardiac event like that. But because of availability of risk prediction models, this patient will have about 40% risk of progression to kidney failure in the next 5 years, and even 10-year risk of cardiovascular risk is about 30% by ASCVD and TWICE 3 trials. When you look at the creatinine value and estimate the GFR, I wanted to stress upon a small discussion about GFR also. Generally, our GFR is about 100 ml per minute. As we age, especially at the age of 30 years, we lose 1 ml GFR every year. That means when your baseline GFR is about 100 ml at 30 years, by the time you reach 70 years, you lose about 40 ml of GFR. You have about 60 ml GFR at the age of 70 years. That's the reason why patients who are having people after the age of 70, the incidence of CKD prevalence is about more than 25 to 30%. What happens when the same patient at the age of 35 develops diabetes and obesity? Instead of losing 1 ml GFR every year, they lose 7 to 10 ml of GFR. So this patient having 50 ml GFR at 40 years, if he loses 10 ml GFR every year, obviously he lands up in dialysis in the next 3 to 4 years. So this is the common scenario we have been following since up to 2016 onward. So I have been in practice seeing thousands of patients since 2003. What we had done so far until 2016 and 17 is, we used to prognosticate the patient that you will have to land up in dialysis in the next 3 to 4 years. And he will be on a mission to find out a kidney donor to undergo kidney transplant later in the part of life. So they have to wait and watch for dialysis and kidney transplant, or at some point of time they will die because of sudden cardiac event at point, many a times. So this is what's happening before 2016. But because of breakthrough understanding of the science, better availability of drug molecules, and integrated technology into our healthcare, a lot of things have been changed for the past 10 years. We are entering into the era of personalized, predictive, proactive care, where you can monitor minute-to-minute glucose readings through a Abbott freestyle replay or a blood pressure monitoring for risk factor control. Even your Apple Watch can track all your health metrics by 24/7 and it enters into your doctor's inbox. And with the availability of newer drugs like Forxica, dapagliflozin, Kerendia with Finrenone and semaglutide, there is a whole spectrum of changes happened for the past 10 years. So where you could be able to avoid lifetime dialysis requirement when you pick up the patient with early stage CKD. So the main question here is identification of the patient in early stage. So I request all the physicians, surgeons, wherever, because 90% of these patients do not come to a cardiologist or a nephrologist. They will be in the hands of a physician or surgeons. So you need to understand basic understanding of the comorbid illnesses of the disease spectrum and the better understanding of CKD and cardiovascular issues. So this is the holistic approach. I wanted to end this because I would like to, because there are 3 drugs will be there which helps in reducing the cardiac and renal events. So I would like to ask Dr. Perai Chaudhary to manage, how you manage this cardiac assessment patient for this patient.
Thank you, Ramakrishna. I would like to thank the organizer for giving me this opportunity. This is a patient, young male, who is obese and has multiple risk factors with CKD and albuminuria. He had asymptomatic CKD as evidenced by QS in atrial leads and RWMI in on 2D echogram. So how to approach this patient? Shall we go directly to angiogram, because coronary angiogram has its own risk in this patient. So as the patient is asymptomatic, I would like to test his metabolic ischemia, myocardial ischemia by non-invasive test. Like the simplest is exercise electrogram, that is by TMT. Other things are by stress echocardiogram, nuclear stress test by SPECT imaging and PET imaging, and the CT coronary calcium score. Mainly it is useful for risk diagnosis, and of course, and finally the invasive coronary angiogram. So first I would like to so this patient, we have to establish the CAD by diagnosis of by non-invasive test. This patient is asymptomatic, so I would like to induce myocardial ischemia by non-invasive test, like TMT, stress echocardiogram and nuclear test. If the patient is positive for by this test, we can go for invasive angiogram and revascularization if in the same setting. If asymptomatic is negative, then we can proceed with careful guideline directed medical treatment and close follow-up. So for what are the reasons for asymptomatic CAD in this patient? Probably one is recalibration, small vessel occlusion, or well-developed collaterals, and infarcted myocardium with no viability. These are the reasons why patient may have asymptomatic CAD. So if the non-invasive test they suggest to high risk features, then you have to straight away go for coronary angiogram and revascularization. If the non-invasive test suggests less invasive, less severe symptoms as it features, then we can go for either gold guided medically guided